will now be going into organ systems. The first organ system that you'll be having would be the respiratory system in the thoracic cavity and the cardiovascular system. Now, you know that these two systems, particularly the lungs and the heart, which are the main organs for these systems, are very important in the process of the human body. So much so that since these two are very important, it has naturally have to be well protected. And if you're going to take a look at the human body, there's no other area in the human body, of course, no, except one, which is the cranial cavity or the cranial vault, wherein you have the brain there securely protected, no, by the cranial cavity. The next area that is well protected would be your thoracic cavity. Now, why do I say this? Because this is the area by which you see a bony enclosure. Bony enclosure that protects the thoracic cavity, and at the same time, the area wherein you have the heart, which is the mediastinum. Okay? So my objective for this morning is for me to be able to discuss the anatomy of the anterior chest wall, particularly the anterior chest wall. Okay? Describe the structures that are seen here, and also discuss another very important organ that you see in the anterior thoracic wall, which is the breast, particularly that of the female breast. Why the female breast? Because the female breast is the well-developed breast tissue. Now, for the males, you only have a rudimentary breast, which is a stunted growth of your breast tissue. Okay. At the same time, correlate common clinical conditions that may affect the anterior thoracic wall and the breast. Okay. Now, as a review, this is the coverage of your chest wall. So you see on the right, the bony enclosure of your thoracic cavity. And this is primarily made up of your thoracic cage. And this is formed by the 12 pairs of your ribs. As you can see here, that goes antero-posterior, from the front going towards the back. Now, on the front, this is connected to your sternum. So you see here, a flat bone, your breastplate or your sternum. And as it goes around, as it goes posterior, this will now be attached to your vertebra, particularly that of your thoracic vertebra. Okay. Now, here in the front, of course, your ribs will not directly come into contact with the sternum. And you have the presence of your cartilage, so soft bone, that will actually connect your rib to your sternum. As you go along, as you go down, you see some modifications. And that modification will characterize your ribs into your common ribs and your irregular ribs. So atypical and typical ribs, I should say. Okay. Well, of course, this will be covered by your skin, a very thin layer of skin. You have your subcutaneous tissue or your fat layer and your fascia. Okay. Now, some of the things that I will be talking about are I just review for you. Remember, like the ribs. So we've talked about it. And by classification, where do you put your ribs in the general classification of your bones? Guys?
Flat.
General classification. Diba, general classification natin, we group the bones or the skeleton into either axial or appendicular, right? So where do you put the ribs?
Eggshell
Eggshell
skeleton.
bone.
Eggshell.
Axial skeleton. Okay, no? So since this is seen at the middle, okay? Now, since the thoracic wall is a fairly large area, no? As far as surface area is concerned, naturally, if we would want to um, characterize a specific location in the thoracic wall, then we will have to have landmarks or guides for us to be able to localize a specific area in the thoracic wall. And in the thoracic wall, we make use of vertical lines. And so we draw imaginary lines to delineate areas in the thoracic wall. And these imaginary lines can be drawn anteriorly, as you can see here, laterally, along the region of the axillary area, and at the back, posteriorly. Okay? So these imaginary lines will either divide the thoracic wall into equal halves, as you can see here, your mid-sternal line, or the anterior median line, which if you trace this imaginary line, will pass through the center of the sternum all the way down, traverse the umbilicus all the way up to the pelvis. If you would want to divide the thoracic wall into unequal sides, you make use of your clavicle as a landmark. And midway from the clavicle, again, draw a vertical line all the way down. And this would be your mid-clavicular line. So you can have two, no? Left and the right mid-clavicular area, mid-clavicular line. Of course, the point of reference would be the clavicle, midway to the clavicle. Okay. Now, your mid-clavicular line will traverse another important structure in the anterior thoracic wall, that of the nipple. Okay. So here. Now, usually, the nipple corresponds to an area in the thoracic wall, specifically at the area of the fourth intercostal space. Well, this is true for the males. This is true for the males and for young females. But that's just it. So we can make use of the nipple as a landmark for the males because this is fairly constant in your fourth intercostal space, and for young women. But as the female age, we don't make use of this landmark anymore because this becomes variable. Variable in the sense that this will follow the bulk of the breast, the size of the breast. Remember, as you age, the consistency of the breast also vary. No? So as you grow older, the breast sag, and you cannot make use of the nipple as a landmark. But one thing that is, again, fairly constant is if you will draw again an imaginary line from the nipple going towards the posterior, meaning at the back, antero-posterior, this will correspond at the level of your T4, your fourth thoracic vertebra. Okay? So did you get that? Yeah?
Yes po, Doc.
Okay. Making use of the nipple, it is constant at T4. No? It corresponds to your fourth intercostal space, but this is variable insofar as your fourth intercostal space is concerned. Now on the lateral side, you have your anterior axillary line. So our point of reference would be the axilla. And the axilla is subdivided into the anterior, mid-axillary, and posterior axillary. Okay, so this is very important, especially if you are dissecting in the axillary region, specifically for the surgery for the breast, in breast cancer surgery, wherein we need to clear the axilla of your lymph nodes. Now, as I've said, no, so in the anterior chest, you have a mid-sternal line and a mid-clavicular line. In the posterior chest, you have your vertebral line or mid-spinal, an imaginary line that will traverse the body of your vertebra, dividing the back into equal portions, and the scapular line. Okay, so the scapular line would be the lines that are synonymous to your mid-clavicular lines that will divide the back into unequal sides. In the lateral chest, you have your axillary lines. Okay, putting it in the proper perspective, looking at it in a patient, these are your lines. So your mid-sternal line, your mid-clavicular line, you have here your anterior axillary line. At the back, this is the vertebral line and your scapular line. And on the lateral side, so dividing the axillary region into three. Okay. Now, aside from these lines, we can make use of your bony indentations of the thoracic wall. And we can make use of this, especially if you have a lean patient or a lean individual, wherein you can actually see or touch these bony indentations. And what landmark can we use? So number one, we can make use of your suprasternal notch. So your suprasternal notch would be at the base of the neck, where you can feel it. So there's a depression here. So the one that I'm showing you. So the depression at the base of the neck, and at the start of your manubrium. So that is your suprasternal notch. Okay. So this wide superior portion of the sternum is your manubrium, and the meeting point of your manubrium and the sternum is your sternal angle of Louis. Okay, the sternal angle of Louis. And what is the importance of this? Number one, your manubrium would be the attachment of your first rib, and your sternal angle will be the attachment of your second rib. Okay. Now, as you go down, you will feel a small diamond-shaped structure. This is your xiphoid process. And so the tip, the edge, the most distal portion of your sternum, which is your xiphoid process. Okay. Now here, we have a patient. So the pictures that you'll be seeing are actual patients. So these are my patients, and these pictures are posted here with their consent for learning purposes. So as you can see here, we have a lean individual wherein you can see all the bony indentations of the anterior chest. You see here your suprasternal notch, your manubrium, the body of your sternum here. Well, your xiphoid is not visibly seen here in the picture, but if you will be able to see this patient, you can really touch the xiphoid process here. And the edge of your rib cage, which is your subcostal margin. Okay, so very much well delineated. And if you will count the spaces of your ribs, your nipple will be seen at the area of your fourth intercostal space, mid-clavicular line, our point of reference. Okay, now here is another view. So this time, you see here the skin removed and the subcutaneous tissue. Now, immediately what you will be seeing in the anterior chest would be your superficial chest muscles. And what are these superficial chest muscles?
Pectoralis.
your pectoralis. No? So you're done with the lecture in the superficial chest wall muscles. So you will see the fibers of your pectoralis major muscle here. Okay. Now on the lateral side, you have your serratus anterior. Your pectoralis minor will be behind your pectoralis major muscle. Okay. So this is a 20-year-old patient, male patient. No? So for your information, you do not see a well-developed breast here, but only the left nipple. No? So later on, I'll be giving you the background history of this patient. Okay. Dissecting the axillary region. No? So you're looking at the axillary area so that the reflection of your pectoralis major muscle. Okay. So this is the medial side. This is the lateral side. This is your serratus anterior muscle. Okay. Now note in the axillary region, you see a fairly amount of subcutaneous tissue or fat tissue. So this is what you're going to see also when you dissect the area. Okay, so let's go now to the ribs. So this is actually the main structure that holds the anterior chest wall. Okay, so you have two subdivisions. You have your true ribs or your false ribs. True ribs, why? Because these ribs actually connect to your sternum. And your first seven ribs, a pair of ribs, will connect to the sternum. Well, of course, not directly, but through your cartilages, as you can see here. Whereas your false ribs, your ribs 8 to 10, and your floating ribs 11 to 12, as you can see here. So why false? Because they subsequently will join first and then attach to the lowermost true rib or directly to the sternum. Okay. So insofar as the anatomical makeup of the ribs are concerned, we also have typical and atypical ribs. And your typical ribs would be your ribs 3 to 9. So when we say typical ribs, of course, most, if not all, of the anatomical landmarks or structures that you see in one rib will be present in the rest of your ribs. So that if you characterize ribs 3 to 9, this will have a head, a neck, and tubercles. So these are fairly regularly seen in ribs 3 to 9. It will have two facets that will connect to your adjacent vertebrae as it goes posterior. Okay? The tubercle will also connect with the transverse processes of your vertebra. The shaft is round superiorly with a sharp edge inferiorly. And at the back, you will see a groove, which we call your costal groove. Now, this groove is very important because your neurovascular structures will be seen here. Your veins, your arteries, and your nerves. And this is the site by which they course through and go around in your ribs in that particular order: veins, artery, and nerve. Okay. Now to show you the illustration and the importance of this costal groove, so look at this illustration. There are times wherein we need to put a tube in the chest. This is to drain either air, fluid, or blood in the thoracic cavity. So accumulation of air, fluid, and blood outside of the lungs, inside the thoracic cavity. Now, normally, Now, what we do is to put the tube either in your fourth or your fifth intercostal space, anterior axillary line, so that you can see here, this is the site of incision. Incision. So that's why I told you it's very important to note the level of your nipple, no? Because we use this as a guide. Now, as we cut through this space, the incision is made at the superior border of the rib. Superior border here. Why? This is to avoid injury to your vein, your artery, and your nerve, because they are seen in the costal groove. And likewise, when you put the tube, you are also maneuvering through the superior border of the rib, so that you will again avoid injury to your neurovascular structures. Is that clear?
Yes, po, Doc.
Okay. So remember that. No? So to avoid any injury to your neurovascular bundle, all procedures should be done at the superior border of the rib and not at the inferior border of the rib. Okay. So what about your atypical ribs? So the rest would be your atypical ribs, your ribs 1, 2, 10, 11, and 12. Okay. So the first rib is the highest, the broadest, and the strongest and the flattest of your ribs. Okay. The angle will coincide with its tubercle. So you see here. So that's the angle, and this is your tubercle. And it articulates with one vertebra. So one vertebra, not unlike the others. No? So this will articulate with successive vertebrae as it goes posterior. Okay? So the first rib will have a tubercle, no, yung Lisfranc, we call it a Lisfranc tubercle, which is the site of attachment for your anterior scalene muscle. So here. So this is the site of attachment of your anterior scalene muscle. Whereas your second rib, so the tubercle is again on the lateral side of its angle, and this is the site of attachment for your posterior scalene muscle. Okay. What about the 10th rib? Okay. So it will have a single facet, one facet in its head, and we often call it the uncertain rib. Why uncertain rib? Because it may be floating or attached to your ninth rib. Okay, so remember earlier, I told you there is a variation in so far as ribs 8, 9, 10, 11, and 12 is concerned. So of these ribs, your 10th rib is that rib which is fairly variable in its orientation. It may be floating or not. No? It may be connected to your ninth rib or not. Your 11th rib will also be single faceted. It will have no neck or tubercle, and the costal groove is not distinct. Okay. Your 12th rib, obviously this is your floating rib together with your 11th rib, will also have one facet in its head, no tubercle, no angle, and no costal groove. So fairly only the rib. No? So only the rib seen, no, or appreciated. Okay. So putting it together in the normal anatomic location. So this will be how it will look like. This is your anterior thoracic wall. So of course, your first 7 ribs articulate with the sternum via your cartilages. So you have your cartilages. Ribs 8, 9, and 10 will join together. Your costal cartilages will join together before joining your sternum. And at the edge of your costal cartilages will be your subcostal margin. So this signifies the demarcation between the thoracic cavity and your abdominal cavity. Well, this is not the major structure that will subdivide the thoracic cavity and the abdominal cavity, because you know that the diaphragm is there. So it's actually the diaphragm which separates the thoracic cavity and the abdominal cavity. But the diaphragm anatomically will be attached here at the edges of your subcostal margin. So that's why we use it as a landmark for the subdivision of your thoracic and your abdominal cavity. Okay? So any questions so far? Question?
Wala po.
Wala, no? So, ano naman, clear naman? Okay. No? So you have here your sternum or your breastbone. So this is subdivided into three parts: your manubrium, the body of the sternum, and your xiphoid process. Your manubrium will have 3 notches, 2 clavicular notches wherein the clavicles will be attached, and 1 suprasternal or your jugular notch. So the body is the biggest portion. And you see here the attachments of the other ribs. At the sternal angle, you have the attachment of the second rib here. Okay. So questions? Yeah. No questions?
Wala po, Doc.
Now, so removing the covering, the skin and the subcutaneous tissue, and dissecting through the external chest wall muscles, and I'm talking about the pectoralis major and the pectoralis minor muscle, you will appreciate now your costal muscles, your intercostal muscles. So where do you see your intercostal muscles? Your intercostal muscles are seen in between the ribs. Okay, so that's why it is called intercostal muscles, and they are subdivided into your external intercostal, your internal intercostal, and likewise you also have your innermost intercostal muscles and your transverse thoracic muscles, which are further subdivided into your sternocostalis and subcostalis muscles. Okay, now dissecting through it in the anterior chest wall. The external intercostal muscles is very important. Okay, so why is this very important? It elevates the rib during inspiration. So it elevates the rib during inspiration, and what does it do? It actually increases the area for exchange of gases, and it increases the surface area of the chest. Okay? So the external intercostal muscle will attach to the inferior border of the rib above and the superior border of the rib below. Now you will see this later on in the laboratory when we show you the dissection, that the external intercostal muscle fibers, as it goes towards the center, towards the sternum, will not be visible, but it will be replaced by your anterior intercostal membrane. So this is to differentiate this from your internal intercostal muscle, which is deeper to your external intercostal. So when you dissect, the external intercostal and go deeper, the next layer of you will be seeing will be your internal intercostal muscle. Your internal intercostal muscle will be attached to the superior border of the rib below and the inferior border of the rib above. And what is the function of this? The internal intercostal muscle depresses the rib above. So these are actual muscles of respiration. So it aids in respiration. But the main muscle of respiration still will be your diaphragm. Okay? So your intercostal muscles are accessory respiratory muscles. Okay? So as it depresses the rib, this happens during forceful expiration. Okay? So what about the third group of muscles, your transverse thoracic group of muscles? So you have three: your sternocostallis, your innermost intercostal, and your subcostal muscle. Your innermost intercostal muscles will have the same fiber direction and action as your internal intercostal muscle, but it will not extend as far as your intercostal space in the anterior area as compared to your internal intercostal. Okay, of the three, the most constant would be your sternocostallis muscle. Okay? This is the most constant of the three. Now, what about your subcostal or your subcostalis muscle? This is the most posterior of the three group of muscles. You will only see this when you remove the lungs from the thoracic cavity. So it's very difficult to identify your subcostal muscle. Here, so this is your sternocostallis. And as I've said, this is an area which is most constant. And the pleura is immediately behind it. Okay, your subcostal. Okay. So what about your intercostal spaces? Now, your intercostal spaces will be the specific areas in between the ribs, and you have 11 intercostal spaces. The upper 9 spaces are closed, and the third intercostal space is the widest, and widest during inspiration. So we've discussed your subcostal group, which is seen at the posterior border of the rib, and this is where your neurovascular bundles are seen. Okay. Next, we go to the arteries. Okay. So what are the arteries that you see in the anterior thoracic wall? So number one, you have your posterior intercostal arteries. So this is made up of branches coming from your highest intercostal artery. So these are the upper two. The origin would be your costocervical tract of your subclavian artery, whereas the lower 9 will be branches of your thoracic artery. So this will have two branches, an anterior one and a posterior one. And you will see this coursing through and passing through the subcostal groove. Your anterior intercostal arteries, this will come from your internal thoracic or your internal mammary artery. So here. So this is subdivided into an upper 6 coming from your EMA, and the lower 5 will come from your musculophrenic arteries. Now remember, this one, no? So yung sa lower rib natin, the floating ribs natin, since you have no 12 intercostal space, so wala. No? So wala tayo. You don't see any artery there. Okay. Now, here in the anterior thoracic wall, the most prominent artery and the biggest that you can see here would be the internal mammary artery. This is the biggest and the longest. So why do I say longest? Because it actually continues through the abdominal cavity via your superior epigastric artery. Okay? So this is a branch of the subclavian artery. In your dissection, you will not be able to see the origin of this, not unless the neck is also dissected already, because you will see the origin of your internal mammary artery in your subclavian artery. So this will subdivide into your superior epigastric artery and your musculophrenic artery. Now, a bit of information, your internal mammary artery is also the artery that is being used very common before. Now, when you are doing your coronary artery bypass graft or your cabbage. So if you're doing heart surgery, cabbage, your internal mammary artery was the common choice of artery to be used. Well, the number one would be your saphenous vein before, no? But your saphenous vein grafts only last about 5 to 7 years, and then this will be occluded. Your internal mammary artery will last 10 to 12 years. But the problem is it's very difficult to harvest it and dissect it. So that's why now the option is to use your radial artery. So that you remove your radial artery, and this is being used as the artery for your coronary artery bypass graft. Okay. So what about your nerves? Okay. Oh, by the way, venous drainage will just follow the corresponding arteries. Okay. No, so that's a general rule in anatomy. You know, for every artery, there is a corresponding vein. So that venous drainage in the anterior thoracic wall will follow the orientation of the subsequent arteries. So insofar as the nerves are concerned, so you have 12 pairs, 11 intercostal and 1 subcostal nerve. So typically, your intercostal nerves will supply the muscles and the skin. Okay? So except for the first intercostal nerve, which forms part of the brachial plexus, and the second intercostal nerve, which crosses the axilla and supplies the posteromedial aspect of the arm as your intercostal brachial nerve. Okay. So the rest, the second to the sixth intercostal nerve, will have thoracic courses, while the 7th and the 11th intercostal nerve travels partly thoracic and abdominal. Okay. Your intercostal and your subcostal nerve will supply the musculature of the anterior thoracic wall. So your external, internal, and innermost intercostal muscles, your subcostal and your transversus thoracis muscle, your levatorum costarum, your external and internal and transversus abdominis muscles, also your rectus abdominis and pyramidalis muscle. So what does this tell you? So it will tell you that the nerves here will also be the nerves responsible for supplying the anterior abdominal wall, all the way down up to the pelvis. So pretty much the same as how your internal mammary artery or your internal thoracic artery will be supplying the anterior abdominal wall via your superior epigastric artery. Okay. So any questions insofar as the anterior chest wall is concerned? Question?
Wala.
Okay. Sige. So let's go now to the last portion, which is the breast. So when we talk about the breast, we will be talking about its boundaries, the blood supply, and the lymphatic drainage, which is very important, especially when you're dealing with breast pathology. And I'm referring to breast cancer as the most common breast pathology that we encounter in the breast. Okay. So the breast is a fairly average size organ, which you see in the anterior chest wall, specifically in women, in female, because you have a well-developed breast. And if you're going to take a look at the boundary of the breast, the upper border would be at the level of the second rib. The lower border is at the level of your sixth rib. Medial border would be your sternal edge, as you can see here. And lateral border would be up to the mid-axillary line. Okay. Now, deep inside the breast, okay, you have your pectoral fascia as the structure that separates the breast from the anterior chest wall. Actually, the breast sits on the pectoral fascia. Okay, so that the pectoral fascia will separate your pectoralis muscles from the base of the breast. Whereas laterally, you have your serratus anterior fascia that will separate the breast from your serratus anterior muscle. Now note here that the shape of the breast is not really round, no, but you have here a tail-like portion of the breast that will actually insert through the axilla. And this is what we call the axillary tail of Spence. So axillary tail of Spence. That is why for females, whenever they have their monthly period and they know it, also they can feel soreness of the breast. It feels full, and actually this feeling can be transmitted through the axillary area, to the axillary region, because of your axillary tail of Spence. Okay, so this is the outline of the breast, the female. Well, of course, at the center of the breast is the nipple, and you have a pigmented area around the nipple, which is your areola. So this is the areola of the breast. The breast will differ in size. So it will depend upon the fat content. So basically, the breast will have three types of tissues: fibrous, fatty, and glandular. The fibrous tissue is responsible for giving form to the breast. Your fatty tissue is responsible for giving bulk to the breast. So I'm referring to the size of the breast. And the glandular tissue is responsible for producing milk during near term, near pregnancy. And is also responsible for that feeling of fullness whenever you have your monthly period. And likewise responsible for the tumors that you have in the breast, the source of the tumors in the breast. Okay, so if you're going to remove the breast, this is how it will look like. So I have here, this is one of my patients wherein you have a mass here. So when you have a breast cancer patient, you totally remove the entire breast. And this is the entire breast. And this is what I am talking about. This is the axillary tail. Okay, going towards the axilla. And you see here, you have lymph nodes. Lymph nodes. So you remove the lymph nodes when you do mastectomy of the breast for proper staging of the cancer. Okay. So the major blood supply to the breast comes from your internal mammary artery. So you might ask, internal mammary artery, major supply of the breast, how come? The internal mammary artery is at the back, nasa likod. No? And we are talking about the breast, which is seen in the anterior thoracic wall. Well, branches of your internal mammary artery traverse your intercostal muscles to supply the breast. And this is what we call perforators. Perforators. In its name, perforators, these are arteries that perforate your intercostal muscles to supply structures in the anterior thoracic wall. And specifically will supply the medial aspect of the breast. So 60% of the blood supply will come from branches of your internal mammary artery. The remaining portion will be coming from branches of your axillary artery. You have your lateral thoracic artery, your superior thoracic artery, and your thoracoacromial artery. This will supply the superior and lateral portions of the breast. Okay? Whereas the remaining portions of the breast will be supplied by your anterolateral and your anteromedial perforators, which will supply the inferior and the lateral portions of the breast. Okay? So this comes from perforators in your 3rd to the 8th intercostal spaces. Again, venous drainage will follow the arterial drainage of the breast. What about lymphatic drainage? So now this is very important because lymphatic drainage will prevent spread of disease, spread of infection, spread of cancer when we talk about breast cancer. So 75% of the drainage of the breast will be via the axilla. So remember the picture that I showed you earlier, the dissection in the mid-axillary area of the breast, clearing out the breast of the lymph nodes. So 75% of the drainage will go to the axillary area, while the rest will be draining mainly into the internal mammary chain of nodes. So along the course of your internal mammary artery. So you have different node levels, and this is based on the location of your lymph nodes in reference to your pectoralis minor muscle. So here, the important structure would be your pectoralis minor muscle. So that level 1 nodes, these are nodes that are seen lateral to your pectoralis minor muscle. Level 2 nodes are lymph nodes seen under the pectoralis minor muscle. And level 3 nodes are lymph nodes seen medial to your pectoralis minor muscle. There are times wherein you can also appreciate lymph nodes in between your pectoralis major and minor muscles. So these are your Rotter's nodes. So we call it Rotter's nodes. And these nodes are seen in between your pectoralis major and your pectoralis minor muscle. There are times also that you will also see drainage going to your supraclavicular nodes. So supraclavicular nodes. And this will be continuous with your axillary apex, at the tip of your axillary chain of nodes. Okay. So you also have internal mammary nodes. These are lymph nodes seen along the edge of your sternum. So all in all, you have around 36 to 40 lymph nodes. So these are normal lymph nodes, 36 to 40 in an individual per side. Doing surgery for breast cancer, we usually remove around 12 nodes, 12 or more nodes. No? But definitely, we do not remove the entire lymph node chains. Your 12 lymph nodes are enough to properly stage your disease. What would be the complication of removing the entire lymph node chain? If you remove the entire lymph node chain, you will disrupt the lymphatic drainage and subsequently will cause edema, no, of the extremity. Edema of the extremity is what we call elephantiasis, and this is a permanent thing. So you will not be able to correct this one, no? And this is very morbid, very morbid for your patient. So again, another view, no, of the dissection. So here, this is the same patient that I showed you earlier. So the breast, we already removed the breast, the entire breast. This is the outline of your pectoralis major muscle. Your pectoralis minor muscle is here. Okay, this is your axillary region. We remove the entire lymphatic chain of nodes, so level 1 and 2, in reference to your pectoralis minor muscle. And also, worth mentioning would be the identification of two very important nerves when you do mastectomy, that of your long thoracic nerve and your thoracodorsal nerve. So these two nerves are very important for identification. This is your serratus anterior muscle, and here at this edge, you will see the edge of your latissimus dorsi. Okay, another one. So this is the edge of your latissimus dorsi. Okay. So this is a 55-year-old female with breast cancer. Closing the chest, it will look like this already. So no more breast tissue. Okay. So remember the picture that I showed you with a circular dissected skin in the chest. So this is a 20-year-old male, with this mass in his breast. Okay. So removing the entire thing, you're gonna see the outline of your pectoralis major muscle plus part of the pectoralis major muscle removed or shaved because this was involved in the tumor also. So note that here, as your pectoralis major muscle go towards the midline, you see the outline of your sternum here. These fibers that goes vertical are your fibers of your rectus abdominis muscle. On the side, obliquely oriented, is your serratus anterior muscle. And again, you see here the edge of your latissimus dorsi peeking through. Okay. So how did we cover this area? So since this is a very big area, we cannot close this primarily like what we did with the other patient. So we closed it by putting a skin graft, getting skin from the thigh, anterolateral portion of the thigh, and then putting the skin here, covering the defect. Okay, so last portion is your diaphragm. So the diaphragm is the structure that subdivides the thoracic cavity from your abdominal cavity. So you have several origins. Number one, your sternal origin from the xiphoid process. Next would be costal, along the costal margins. The crura, which is seen on the left and on the right side, and the ligaments. Okay. As I've said, your diaphragm is the major muscle of respiration. So this controls the expansion and the deflation of your lungs during inspiration and respiration. This is innervated by your phrenic nerve and will have a fairly amount of blood supply coming from different branches. You have your pericardiophrenic artery, your inferior phrenic, musculophrenic, and your intercostal arteries. You have three openings. Okay? Your aortic hiatus at the level of your T12, wherein you see your aorta, the thoracic duct, and your ascydus vein coming out. Your esophageal hiatus at the level of T10, wherein you have the right and the left vagus nerve and the esophageal branches of your left gastric artery coming out, and that of your inferior vena cava at the level of T8, where you will find your inferior vena cava, your right phrenic nerve, and your lymphatic vessels accompanying your inferior vena cava. I think that's the last one. Yep, last one.